Hi everyone. In this video we're going to talk about the thyroid gland. We'll start first with hyperthyroidism. So hyperthyroidism, also called thyrotoxicosis, this is a hypermetabolic state that results from excess production of T3 and T4. So T3 and T4 are your thyroid hormones. We call T4 is thyroxine, and we can measure the levels of T4 and T3. When you have high levels, you have elevated thyroid hormone levels. The symptoms that you have include things like nervousness, anxiety, heart palpitations, tachycardia. They're very tired. They'll have tremors. They'll have a really big appetite, but they'll be losing weight. They're very intolerant to heat. They sweat a lot. They will often have an enlarged thyroid. Okay, that's called a goiter. Most of the time when we're talking about hyperthyroidism, we are talking about women, okay? Most common cause of hyperthyroidism is Graves' disease. Graves' disease is an autoimmune disease characterized by the production of antibodies that activate the receptor for TSH. So your thyroid cells have a receptor on them that TSH sticks into to stimulate the thyroid gland. And so these antibodies mimic TSH. They stick to the TSH receptor and they tell the thyroid gland to start producing a whole bunch of T3 and T4, and the thyroid gets bigger. Now, you can also have other causes like overgrowth, like nodules in the thyroid gland. You can have a thyroid tumor. You can have inflammation of the thyroid gland. And very rarely will you have a pituitary tumor that is secreting TSH, but it's a possibility. Remember in the pituitary video, we talked about that, right? Hyperpituitarism. So we diagnose hyperthyroidism based on just lab values, okay? And if your T3 and T4 levels are really high, typically with negative feedback, that means your TSH level will be low, and that's a primary hyperthyroidism. If your TSH level is also high, it means that the thyroid is just doing what it's told, and that's that pituitary tumor secreting TSH. If it goes into a crisis, we do call that a thyrotoxic crisis or a thyroid storm. So here again is a review of the symptoms, okay? And here is your little cartoon character that also has some symptoms. One of the things I want to remind you is when we have changes to hair and skin, it's almost always an endocrine problem. So be very aware when patients are telling you that their skin has changed or their hair has changed. So in hyperthyroidism, the hair becomes very fine and straight, and that's going to be different from hypothyroidism, which we'll talk about in a minute. So how do we treat hyperthyroidism? Well, we have to either kill the thyroid or we have to suppress the production of thyroid hormone, or we have to treat the symptoms. So typically we will either remove all or part of the thyroid gland, or we will kill it off with radioactive iodine. So if your patient is hyperthyroid and they're having, especially if they're in a thyroid storm, we do treat the symptoms with beta blockers, because your worst symptoms, your most dangerous symptoms, are going to be that tachycardia and hypertension. And often they will present with dysrhythmias. Sometimes they'll have new onset AFib. Anybody who comes in with tachycardia or new AFib, one of the first things we do is check their thyroid level. So we will treat the symptoms with that. Now we can kill off the thyroid with radioactive iodine. Remember that your thyroid cells are the only cells in your body that take up iodine. And so the radiation can't affect any cell in your body except the thyroid cells. And so that kills off those thyroid cells and makes them inactive. And same way as if we removed it. Now, if it is cancerous, we will probably remove the thyroid if it's cancerous. Either way, whether we kill it off with radioactive iodine or we remove it surgically, your patient is now hypothyroid and has to take thyroid medicine replacement therapy for the rest of their life. Now, we do have a couple of anti-thyroid drugs. PTU, propylthiouracil, prevents the thyroid gland from making the hormones, and methimazole or tapazole, that actually blocks the thyroid hormones. We do have to be kind of careful with those because they can cause bone marrow toxicity, which can cause leukopenia, low levels of white blood cells, which means they're more sensitive to infection. So this is your tapazole here, and got your little cartoon here. I'm going to change this as we sit there. There we go. There's our little tapazole cartoon. So you can see here that the tapazole, you still have your T3 and your T4 and your iodine, but tapazole is blocking it. So he's like the bouncer. If your patient is pregnant, they cannot take tapazole. They have to take PTU instead. Because this is blocking all of these things, if we eat foods high in iodine, we're using it all up. And so you got to educate your patients to avoid foods that are high in iodine, like my favorite, soy sauce. You do take it with food. These medications, take them with food. And this is true of all hormone medications. Take them at the same time every day. Don't skip doses. Don't stop them abruptly. Now let's go to the other end of the spectrum and we'll talk about hypothyroidism. So this diagram here compares hypothyroid and hyperthyroid. So you can see the differences between the two and you can compare them side to side. Like here, hypothyroid causes constipation, hyper causes diarrhea. Hypo causes cold intolerance. Hyper causes, well, I thought it was going to be right here, heat intolerance. So hypothyroidism is a hypometabolic state that results from a deficiency in T4 and T3. So major clinical manifestations, they're still tired. Remember, hyperthyroid patients are tired because they can't sleep because their metabolic rate is so high. Hypothyroidism, they don't have any metabolism, so they're constantly tired. Cold intolerance, I talked about that. Their hair is going to get very dry and brittle and break off, whereas in hyperthyroid, remember, they have that fine, thin hair. We do see hypothyroidism more often in women, and the most common cause is actually chronic autoimmune thyroiditis, which is Hashimoto's disease. So it's yet another autoimmune problem, only this time, instead of the antibodies pretending to be TSH, these antibodies actually destroy the thyroid gland. The other real common cause of hypothyroidism is taking out the thyroid gland because you had hyperthyroidism, or maybe you had thyroid cancer. It can happen because you don't have enough TSH. So remember that we talked about primary and secondary when we talked about hyper, and the same goes. If your pituitary gland isn't secreting TSH, then your thyroid gland isn't going to secrete thyroxine. But that's pretty rare. Usually your patients who are hypothyroid have Hashimoto's disease. And we do measure the TSH level, and we measure your T4 and T3 level. Congenital hypothyroidism is in kids, and it causes a very low metabolic rate. It causes them to have a lot of developmental delays. So that's, and when mom is pregnant and hypothyroid, we have to make sure that mom's thyroid levels are regulated, that she stays on her thyroid medication, because the fetus also needs thyroid hormone in order to grow and develop. So what's hypothyroidism look like again? We also call it myxedema here. So remember, here's your cartoon. Okay, so we've got that hair loss. They're going to be depressed. They might complain of muscle aches and pains. These right here, late clinical manifestations, this is the opposite of a thyroid storm. This is where we call it a myxedema coma. Their temperature will be very cold. They'll be bradycardic. They will slip into a coma because they literally won't have enough, they won't even have the metabolism needed to stay awake. Okay. So very, very dangerous. They have to get IV thyroid hormone. So how do we treat hypothyroidism? We give them supplemental thyroid hormone. It's called levothyroxine. It is synthetic T4. Comes in a couple of brand names, Synthroid and Levoxyl. Synthroid's your most common one there. And it works the exact same way as T4 does. So it replaces what your thyroid hormone can't do, either because you had Hashimoto's disease or because we killed off the thyroid because you had Graves' disease. So with this, the first dose isn't going to touch your patient. It takes at least a week, and then before they're going to see any effects. After about 2 weeks, they probably will be feeling better. We will check their thyroid levels after 30 days just to make sure we don't have to adjust their dose. And what we are looking for is not just the thyroid hormone levels, but also the patient's perception of how they're feeling. So if they have symptoms of hypothyroidism, then they have too low of a dose. If they have gone into hyperthyroidism, then they have too high of a dose. So it usually takes a couple times before we get them on a nice, good level. Hypothyroidism of pregnancy, I did mention that. Just remember that our pregnant women have to stay on their thyroid medicine. So side effects of this is going to be there's really no side effects if you are on the correct dose. If you are on too much, then the side effects are going to be that of hyperthyroidism. So take a look at all of these. They're just hyperthyroidism. One note that I have down at the bottom, if you have a patient who is really sensitive to their thyroid meds, and then missing a dose when it's time for their dose, they may actually become a little bit bradycardic. And it just means that they're just barely skirting the line of normal probably. And so they need their dose right away. All right, so cautious use for those with cardiac disease, hypertension, or pregnancy. But remember that this doesn't mean we stop it. It just means we monitor it. Okay. And really it's just, we got to make sure they don't get on too much. Okay. Take it once in the morning, and we take it in the morning because it prevents insomnia, because it increases your basal metabolic rate, and everybody's basal metabolic rate decreases at night. And so we also take it before breakfast on an empty stomach. That's the way it is absorbed best. Don't switch out your times. Don't change schedules. If somebody is going to night shift, what they'll have to do is gradually, make the time of day that they take it a little bit later. So they can't suddenly start taking it at night. They have to take it a few hours later, and then the next day it's going to be a few hours later until they get on a new schedule. Don't skip doses. Don't double up on doses. Be careful and make sure you educate your patient about symptoms of hyperthyroidism, and also make sure they're educated about over-the-counter medications, especially anything that it says it affects alertness and energy levels, because those may interact. Some more implications here. Make sure they tell everybody, all of their doctors, that they're on it, and they should wear a medical alert bracelet as well, just so that if they are found unresponsive, that they know they have a thyroid problem, and so they can look to see if that's if that's what the issue is. Thyroid meds, Synthroid, does make your anticoagulants like Coumadin work a little bit better, and so they might need to decrease the dose of their Coumadin, but they may need to increase the dose of their diabetic meds. And they may need to increase the dose of their DIG. Again, it doesn't mean that we take them off their thyroid meds because they still need their thyroid meds. How do you know it's working? Are they back into what we call that euthyroid state, EU? That abbreviation or that prefix in front of a word means that it's normal, okay? And then monitor for your adverse effects. For your synthroid, remember that would be edging into hyperthyroidism, and it could cause dysrhythmias like atrial fib. Anti-thyroid drugs, remember they can cause bone marrow suppression where you get that leukopenia. And if you don't have any white blood cells, you're not going to be able to fight off infections. All right. The parathyroids. Remember that your parathyroid glands sit on your thyroid glands, and you usually have 4, but you can have anywhere from 2 to 6. I think I said glands, plural for thyroid. They sit on either side of your thyroid gland, and they make parathyroid hormone. Parathyroid hormones function, its entire function. The only thing it does is it takes calcium out of the bones and puts it into the bloodstream if your calcium level is low, okay? Primary hyperparathyroidism would come from the parathyroid glands themselves just being overactive. If it's secondary, it comes from another disease process, and usually that chronic disease process is cancer, okay? Symptoms of hyperparathyroidism. Your calcium levels, your serum calcium levels are going to be super, super high because it's leaching them all out of your bones, which means you're going to have osteoporosis and pathologic fractures. And then the kidneys have to get the calcium out of your bloodstream, which means you're going to have a lot of calcium in your urine, which means you're going to get kidney stones. And remember that inversely related to calcium is your phosphate. And so since your calcium levels are super high, your phosphate levels are going to be super low. All right, hypoparathyroidism. These are abnormally low parathyroid hormone levels. This is usually caused by thyroid surgery. Remember that the parathyroid glands sit on the thyroid gland, and so if we remove the thyroid gland, it's really hard to not remove your parathyroids. And so if we remove the parathyroids, we try to leave at least one, because then it's easier to regulate calcium levels. I had a patient once who they reimplanted one of his parathyroid glands in his arm. It was very strange. But in this, you don't have any parathyroid hormone, which means all of the calcium is in your bones and not in your bloodstream, which means you have hypocalcemia and hyperphosphatemia. So absolutely take a look at your electrolyte imbalances and look at the symptoms of those one more time. All right, a little bit of review, and these review questions will also be reviewing the pituitary. All right, when administering octreotide to a patient, it's most important for the nurse to assess which parameter. Pause and answer that to yourself. And that is B, blood sugar. Octreotide can cause your blood sugar, blood glucose levels to be very labile. Okay, a patient will be receiving somatropin. The nurse expects that the patient has which disorder? Pause and answer this to yourself. And that is B. Somatropin is human growth hormone, and we use that to treat hypopituitary dwarfism. A, adrenocortical insufficiency, that's cosyntropin. Esophageal varices is octreotide, and septic shock would be vasopressin we would use for septic shock. A patient who is taking a thyroid replacement medication tells the nurse that she's starting to experience cold intolerance, depression, constipation, and dry skin. The nurse anticipates that these manifestations are caused by what? That would be A. A return of your symptoms of hypothyroidism means that she is getting an inadequate dose. Okay, which information will the nurse include when teaching a patient about thyroid replacement therapy? That is D. So your Synthroid, your thyroid meds are best taken half an hour to an hour before breakfast on an empty stomach. That enhances their absorption. That helps you to maintain a constant hormone level. And we take it in the morning to help prevent insomnia. We never abruptly discontinue it. And lifelong therapy is the norm. And it can take 3 to 4 weeks to see the full therapeutic effects. Okay, a patient's been taking levothyroxine for 6 months. After this month's lab work, the NP tells the nurse that the patient is euthyroid. What does that mean? That is C. Means that normal thyroid levels have been achieved. Which would be the best menu choice for a patient who's taking an anti-thyroid medication? And that would be pasta. Patients should avoid foods high in iodine, like soy and tofu and seafood. Okay, which effect does the nurse expect to see in a patient receiving hydrocortisone? This is kind of a flashback to a while ago from last semester and a preview of the adrenal glands. This is B. Hydrocortisone is a steroid. It's the drug form of cortisol. Cortisol is an anti-inflammatory in our body. And what it does is it decreases inflammatory leukocyte functions. It decreases scar tissue formation. And it causes you to retain sodium, which causes hypertension. So that is B. Last question. Patient is in pulseless cardiac arrest. Which medication does the nurse anticipate administering out of the ones that we talked about today? That is A, vasopressin. So that is in larger doses. It's a very potent vasoconstrictor, and so it can be used in codes such as different types of shock. It's also in our ACLS guidelines. Remember, desmopressin was for diabetes insipidus. Concentropin is used in the diagnosis of adrenocorticoninsufficiency. Somatropin is synthetic growth hormone. And that concludes this narration.